So welcome everybody to this new version of JACC's Reports webinar, and it will be also associated with a podcast on a very interesting paper that it's going to be published on this Wednesday at 2 p.m. Eastern Time. And this has a title, a case series of parturients and mechanical mitral valves, anticoagulation management during labor and delivery. And we have here with us the first author, Dr. Alexa Nicholas, and of course the second author, Dr. Malamo Kontouris, and Dr. Eduardo Zancanaro, who is a cardiothoracic surgeon. And each colleague will introduce themselves as we move along. Now, the first thing to do is to introduce myself, Julia Grabs, I'm the editor-in-chief, and then we are moving ahead with Dr. Alexa Nicholas, who will present this case series in around 3 to 5 minutes. Alexa, the word is yours.
Hi, thank you so much for having me. I'm really excited that there's interest in this topic. My name is Alexa Nicholas. I'm an adult cardiothoracic and obstetric anesthesiologist. I wrote this case series to highlight some of the unique considerations and challenges associated with different approaches to anticoagulation management during labor and delivery in women with mechanical heart valves. In this case, it was specifically mechanical mitral valves. So just as a little bit of background, there's a lot more guidance about anticoagulation during pregnancy. However, there's very, very little surrounding the time of labor and delivery. And this, of course, is a period of high risk for bleeding, thrombosis, and anesthetic complications, which can include aspiration, failed intubation, increased blood loss, and even death. So this series describes 3 cases. All patients were on warfarin before pregnancy with their mechanical mitral valves. They were converted to enoxaparin upon positive pregnancy tests, and then back to warfarin in the 2nd trimester. And then at about 36 weeks gestational age, they were converted again to enoxaparin. All of them also received aspirin 81 milligrams. So starting with the first patient, she was a 35-year-old with mechanical valve placed at the age of 13 for rheumatic heart disease. This patient was very afraid of laboring without an epidural, and also she was opposed to any possibility of general anesthesia. So she actually just elected for a scheduled cesarean delivery, which occurred uneventfully under spinal anesthesia. And then enoxaparin and warfarin bridging were restarted in post-op day 1. However, she re-presented on post-op day 4 with a complex abdominal wall hematoma, which required operative exploration, blood transfusion, and interruption of her anticoagulation. So she, in fact, had, of all the patients in the series, she had the longest time off of anticoagulation of any patient. Patient 2 was 32 years old, history of substance use disorder on buprenorphine, and she had her mechanical mitral valve placed at the age of 25 for endocarditis. She did have a valve pannus with an elevated mean gradient, so our cardiologist recommended interruption of anticoagulation limited to no more than 24 hours. She underwent induction of labor with a heparin drip, and then had inadequate pain control using nitrous oxide and fentanyl patient-controlled analgesia. So her heparin was turned off when she was 5 centimeters of cervical dilation, which we used as a marker for active labor. And then we anticipated epidural placement. However, before we could do that, she developed chorioamnionitis and had to go for an emergency cesarean delivery under general anesthesia. And that was because there was an inadequate time since being off of the heparin infusion. Her post-op course was complicated by volume overload, atrial fibrillation with rapid ventricular response, which required treatment with metoprolol and diuresis. And then our third patient was a 26-year-old with congenital AV septal defect requiring multiple cardiac surgeries as an infant, with valve replacements at 3 months and again at 7 years old. She had elevated valve gradients as well due to small valve size. So again, our cardiologist recommended a period of 24 hours anticoagulation interruption. She was very motivated to labor without an epidural. And so during her induction, though, she was in a lot of pain. So she tried to use a remifentanil PCA, but ultimately requested an epidural. Kind of like patient 2, her heparin infusion was also stopped at 5 centimeters of dilation, and her coagulation studies were normal 6 hours after that. So she had her epidural placed just in time for her delivery. And her enoxaparin was restarted 4 hours after delivery, and she had no postoperative complications. So those are the 3 patients in the case, and I'll hand it over back to you. Thank you.
Thank you so much, Alexa, and congratulations again for this publication. Malamo, first of all, how difficult it is to manage pregnant women that they are in labor, they have a mechanical valve, and we see that in the guidelines, there are a lot of gaps in evidence. So as you were writing up this clinical case series, what did you think that there are most important gaps in evidence in the current guidelines?
Thank you so much. I'm Malamo Contreras. I'm a cardiologist and specialize in cardiobstetrics at the University of Pittsburgh Medical Center. So, in answer to the question, we have a couple key guideline statements from the American Heart Association, the European Society of Cardiology, the Society of Maternal Fetal Medicine, for how, best to manage patients with valvular heart disease and anticoagulation during pregnancy, and also, around the delivery time period. The challenge is that peri-delivery, it's a lot of things are unpredictable, and the management can become very nuanced. And oftentimes we have to make decisions on a case-by-case basis. So what we know is that there's a high risk of valve thrombosis in pregnant individuals with mechanical heart valves. That risk is somewhere between 4 and 7%. If someone has valve thrombosis, that's associated with higher mortality. So that's often what we worry the most about as cardiologists. But another important consideration is the kind of high morbidity that's carried with hemorrhage that we actually see far more commonly in these patients, somewhere between 23 and 50%, as we've highlighted by this case series. So I think we want to minimize time off anticoagulation, but what is sort of less well-defined or definitive recommendations of when do we stop anticoagulation peri-delivery with induction of labor to allow for appropriate timing of neuraxial anesthesia. And those things are, not, even though we plan well, not always executed to our intent. Although C-section is an attractive mode of delivery, it feels more controlled. The risk of bleeding with that may be higher once we reinitiate anticoagulation. We really need this, series, I think, helps us sort of decide how to balance minimizing time off anticoagulation, providing adequate pain control for our patients during delivery, and then also considering how do we lower the risk of bleeding. With that, I'll kind of go to Dr. Zancanaro if he could maybe weigh in on his opinion from the cardiothoracic surgery perspective.
Thank you very much, and thank you very much for this to be here in this really wonderful session. I'm Dr. Zancanaro I'm cardiothoracic surgeon from Italy, San Raffaele, and JACC Journal Case Report social media editor. This is a really interesting topic. But I would flip-flop a little bit the conversation here, because I got a patient like 1 year ago, and several cases from my colleagues about this topic. And there is a tendency here in Italy in particular to prevent this problem, because I read one of the really interesting article from Dangas et al. About the thrombosis of mechanical valve. Is a super demanding problem for us as a surgeons, in particular for this type of patient. But there is another interesting fact that is the prevention of this problem, which is to do a program with the patient to put, for example, first a biological valve, then have a pregnancy, and then after that do another intervention, do mechanical valves. In particular, with the new era of TAVI and this transcatheter approach. This is a very important thing, because I remember a patient very young, we decided to put a TAVI on the patient, and then he had two pregnancies, and then we have performed a perfect classical surgical intervention with the mechanical valve and without any problem. So this is the point. We need to think not to arrive at that situation, even though this case report is fundamental for our clinical practice. But I would like to flip-flop a little bit and saying maybe we should, of course, put a prevention idea on that. Julia, what about the UK experience about what I said also about like maybe before biologic and so forth, but in general, the topic of mechanical valve and anticoagulation in pregnancy.
So in this interesting, Eduardo, because in this paper, those that they will read the paper from Alexa and Malamo will have the opportunity to see as one of the references being the UK cohort of women that they have mechanical valves and they are actually undergoing pregnancy and labor. And they describe 58 women that, so they say that the percentage of mechanical valves actually in the pregnant population and having labor are 3.7 every 100,000 women that they are undergoing labor. And it's important because it seems that it's the longest cohort of patients, 58, but so important, 58 women. And also they highlight that it's again the importance of low molecular weight heparin on how to bridge these patients and of course then switch on and off from warfarin. Now, going back to the paper, and I would like to ask Alexa and Malamo, if they were to summarize the take-home messages for the fellows, what would they be?
Okay, so I think Malamo did a really nice job already of summarizing some of the key takeaways. But some things I would add would be to reserve the decision to proceed with a cesarean section just for obstetric indications. I know classically a lot of people were performing C-sections for the reason of anticoagulation, in these patients with mitral valves. And I would, recommend just leaving it for OB indications because in our study, the patients that had cesareans had the higher complications, and one of them required general anesthesia as well. And then the other point that I think is important from our paper is that there really isn't a minimum cervical dilation cutoff required to initiate epidural labor analgesia. In our study, we used a cutoff of 5 centimeters as a representation of entry into active labor. However, I believe that cutoff was too stringent because there was poor pain control. And then also one of the patients needed general anesthesia because of this instead of neuraxial anesthesia. So in addition to considering cardiac and thrombotic risks, I think, considering supporting a successful vaginal delivery with use of an earlier epidural should be considered when making the plan for determining the interruption of anticoagulation. The evidence is very limited in regard to this topic. And there's not really, the guidelines don't account for specific patient risk factors. And so I think these decisions really have to be made on an individual basis. And this requires multidisciplinary team planning with the cardiologist, the obstetrician, and the anesthesiologist. And then in my paper, I made a figure and suggested an alternative to what we did, an improved recommendation for when to stop the anticoagulation.
Thank you very much, Alexa. Malamo, we see more and more the specialty of cardiobstetrics and also the women's dedicated to cardiovascular health clinics. How important is this subspecialty for those that they are thinking to do cardiobstetrics and also, like women's heart?
So I think our multidisciplinary subspecialty team is key for success of the management of the complex kind of cardiac pregnant patient. The key players in this are obviously the obstetricians and maternal fetal medicine specialists, cardiologists, anesthesia, and then, depending on sort of the situation, there may be other groups that come into play in collaboration with the patient, because I think that the patient's values also need to be incorporated in how we manage them. So I think it's particularly in cardiobstetrics where complex patients and events are so rare, we need to have subspecialists who have expertise and have experience taking care of them.
Thank you very much. This was a really interesting session, and I thank you, Alexa and Malmo, for this opportunity to be here in our podcast. Congratulations for the paper, congratulations, and thank you for overviews. I thank you, Julia, because it's the core energy of this podcast, and I thank you all for the attention. And we will have this really super interesting podcast in a monthly basis. So I thank you very much for JACC Case Report, and bye.
Thank you. Bye-bye.
My pleasure.
Thank you very much.